I would like to welcome you to this session on the Partnership for Primary Care. I would like to give a special welcome to Dr. Andrew Mua, CEC Health in Makueni County and Chair Council of CECs in Kenya. The Partnership for Primary Care is the first public-private partnership model for primary care in Africa, and it aims to transform the delivery of public primary care in a financially sustainable manner. It's a collaboration between the government of Makueni County in Kenya, Amref Health Africa, and Philips, with the Dutch development bank FMO as a financial co-developer. Combining the strengths of these partners led to a strong synergy. We started this collaboration almost 4 years ago already. I still remember the first workshop we had in Makueni County very well. These discussions were definitely premature back then, but the long-term vision and the good vibes were already there. And that since then, that never changed. We defined back then the most pressing health issues in Makueni County. We also defined the most pressing issues when it comes to the delivery of healthcare. And then you can think about managing of the system or how to financially sustain it. We painted ourselves a picture of how we can address all these issues, combining the strengths of all these partners. A lot has happened since that first workshop. We jointly developed a primary healthcare model where every partner takes the responsibility for those elements where they are best positioned to do so. And that led to the fact that Makueni County is responsible for the facility health staff and for managing supply chains for pharmaceuticals, for commodities. Amref took the responsibility for setting up community health units, for enrolling families into health insurance, for capacity building and quality management. And Philips is responsible for supply and maintenance of equipment and IT systems. We tested this model in 3 facilities and we saw very good results from a health impact point of view, but also from a financial sustainability point of view. After this feasibility study and based on the results that we saw, the parties decided to scale this model to the rest of Makueni County. And we aim to do that as a PPP under the Kenya PPP Act. And in this session, we will discuss all aspects of this model, approaching it from different angles. So from here, I would like to hand it over to Natasha Sanderji to introduce our excellent panelists and start the discussion. And I wish you all a very inspiring meeting.
Fantastic. Thank you so much, Danny. And good morning, good afternoon, good evening to everyone joining us for today's discussion. As Danny shared, my name is Natasha Sanderji. I serve as the Global Health Lead for Accenture Development Partnerships, which is Accenture's social impact practice. As I reflect on my career and the 15 years that I've had to work on exciting issues in health system strengthening and digital health, I have to say the time I spent supporting the Partnership for Primary Care was definitely one of the best times. And so I'm honored today to serve as your moderator to discuss this effort. Over the course of the conference, you've heard many speakers discuss the importance of strengthening primary care. It is one of the most efficient, fair, and cost-effective ways to achieve health impact. It is for this reason that the Honorable President Kenyatta has identified universal health coverage as one of his big 4 objectives. The Partnership for Primary Care is a first public-private partnership model for primary care of its kind in Africa. And as Danny shared, it's really about leveraging the complementary capabilities of Amref Health Africa, the government of Makueni County in Kenya, and Philips to transform primary healthcare in a financially sustainable way, targeting both the demand side, but also the supply side of primary care. Since this model was conceived in 2017, the partnership team has really been able to achieve fantastic results. In fact, one of the health centers that was part of our feasibility study, Imali, has received a People's Choice Award for the past 2 years in a row, recognizing it as one of the top 3 best public health facilities in Kenya. So today's session is really going to explore why this partnership came together, the roles and responsibilities across the different partners at the table, the results that we achieved from that feasibility study, and how this PPP was structured for scale. And we've really assembled a fantastic set of panelists to take you on this journey. The first, Dr. Andrew Mua, CEC Health of Makueni County and Chair Council of CECs for Kenya. Second, Dr. Catherine Kanari, Head of Clinical Business at Amref Health Innovations. Third, June Omelo, Project Manager of Philips East Africa. Fourth, Karnika Yadav, Associate Partner at IntelliCap Advisory Services. And fifth, John Ponsonby of Ponsonby Consulting and a brilliant PPP expert. Panelists, thank you so much for joining us today. If you're not already on video, please come on video so that everyone can see your beautiful faces as we start into the discussion. To the audience, please feel free to type your questions in the chat window throughout the discussion. We'll try to reserve the last 10 to 15 minutes of the conversation to address some of these. I'd like to actually start with you, Dr. Mulwa, if you don't mind. Thank you so much again for joining us today. It's so lovely to see you again. Coming back to the beginning of the partnership discussions that Danny was mentioning 4 years ago, your leadership in Makueni County was critical to sparking this idea and conceptualization of the Partnership for Primary Care. And part of that was due to your focus on improving health outcomes and ensuring health and well-being for your population. What were really the pressing health challenges that you were seeing in Makueni County, and what really drove this idea of developing the Partnership for Primary Care?
Thank you very much, Natasha, for that introduction. Maybe for clarity, my name is Dr. Andrew Mulwa. I am the County Executive Committee member for Health Services in Makueni County. Last week, I am the chair of the County CECs for Health Emeritus. My term of service in that office ended last week, and therefore I am no longer the chairperson of the County Ministers for Health in the country, but I have served in that office for First, I would like to begin by saying that sorry for my internet interruption. I hope we shall be able to pull through without further disruptions. I think when devolution happened in this country in the year 2013, I was fortunate to have been working in the Ministry of Health, the central ministry before devolution. And I had first-hand experience, first as a clinician in the hospitals and a mid-level manager in the district and in the hospital, just before devolution, the challenges that we were facing then. I think much as the priority of the country all along has been strengthening primary healthcare so that primary healthcare becomes the foundation for delivery of health services in Kenya, there have not been a commensurate commitment in terms of resourcing the primary healthcare system in the country. And I still remember those days when I first became the district head. We had a cholera outbreak in some part called Kalawa in Makueni. And my first induction into office was setting up camps and everything because of cholera caused by lack of access to clean water and simple issues of sanitation in the community. And issues of nutrition, I still remember at the time we had a standing at 42% in the district that I was heading at that time. So clearly it was, in my mind, it was clear that for a health system to deliver the service that is required to do, one had to focus on strengthening the primary healthcare. And when we began devolution, our primary focus was strengthening access to primary healthcare services at the level of level 1, level 2, and level 3 services. Level 1 being the community services, level 2 being dispensaries, and level 3 health center, so that as many people as possible would be able to access primary healthcare services. But the access to maternal and child health services, including reproductive health, family planning services, was a major concern. The maternal mortality at the time was 562 deaths per 100,000 deliveries, which was really disturbing. And we had to do something to change that. So therefore, when devolution came, we were able to invest a lot in primary healthcare system, increasing the number of facilities from 109 facilities in the country, in the county, which is 100 primary healthcare facilities precisely, to 225 primary healthcare facilities now. What this meant is more people were able to access primary healthcare services closer to their home. We also ensured that the range of services that were available in these primary healthcare facilities were improved, particularly reproductive health services and maternal and child health services, where issues of immunization, we were able to have near 100% immunization coverage in all these primary healthcare facilities. We were able to ensure that we have the delivery services. At the beginning, we only had 37 facilities that were offering maternity services or delivery services in the county. Now we have 234 facilities that are able to conduct a delivery within the county, which is a big leap in terms of access to these services. We also had challenges with access to emergency referral services, and we established a county ambulance service. Having done this and ensuring that there is an uninterrupted supply of essential commodities. For the record, when I used to work in the district, the citizens actually knew the KEMSA lorries. The KEMSA is the Kenya Essential Medical Supplies Agency, which is the bulk supplier of essential medical products in the public sector. And the citizens actually had known, would see lorries come, and they would identify them. They would say the KEMSA lorry has come, meaning drugs have come. And the following day they would wake up and come to the facility. Some even when they are not sick, because they know the drug would not be there after a week. So someone would come and say they have a headache. Someone would say they are coughing when they are actually not coughing, because they want to hold stocks, because they know the supplies have come and they are not going to last more than 2 weeks. And the cycle would go. We have deliveries, 2 weeks of stocks, then we get out of stocks. Then for 3 to 2.5 months, we would have no stocks. And this was really disturbing me when I became the CEC. And this is one of the areas that we ensure that we have strength. Having done all this, we felt, yes, as a health sector, we have like almost reached the optimum that we could do. We had gaps in terms of management, obvious gaps in terms of the fiscal space, because to invest in these investments that I've just talked about required a lot of money, and we could not possibly continue having the health budget grow every year. And we also realized that one of our capacity or limitations was, despite being a government, was the ability to have strength in working with communities so that the level 1 services are strengthened. We also realized that we had a challenge with access to secondary care and tertiary care, because most of the population was not covered by any form of insurance. And through that, we established what is called the Makueni Care health insurance model, which is more of a community-based health insurance model, where households pay just $5 to access secondary services in our level 4 and level 5 facilities within Mcqueen. Then we realized that our resource envelope was limited, and therefore, for sustainability of Makueni Care, it would be practically impossible to handle all cases, because having removed the financial barrier to access to level 4 and 5 facilities, most of the community would go straight to level 4, go straight to level 5, without seeking services in level 3 and 2, despite the services being there. So it became important for us to ask ourselves, how can we change or develop a model that guarantees that services will continue to be delivered at level 2 and 1, 2, and 3, where delivery of such services is cheaper and where it's more effective, cost effective, and access to many people is also guaranteed. So it is through that we realized that we had gaps of commodities, because even as we were strengthening the commodities, we could not. There are also some basic investigations that we could not be able to do in the level 5s, and especially the financing and the strength that Amref comes with of working with communities, especially in the community health strategy. We thought if we would be able to tap in this and tap in the capital or equity from the private sector, in this case, Philips, to develop a model that would guarantee that the gaps that we were experiencing in this new improved health system would be guaranteed. And that's what both the Partnership for Primary Healthcare program, which has been exciting, I would say, for the last 4 years, and has shown promise of tremendous efficiency and improvement in service delivery in Makueni County and beyond. That would be it from my end. I'm not sure whether I've taken too much time. I can speak about what we have done. Thank you, Natasha.
Thank you so much, Dr. Mullah. That was an absolutely brilliant overview of your time in Makueni County, the fantastic investments you made in expanding access to facilities, the gaps you were still seeing around management, fiscal sustainability, and this idea of developing a model that would encourage and incentivize people to seek care in level 2 and level 3 facilities versus seeking care in the level 4 and 5 facilities. And you also brilliantly touched upon kind of what inspired you to bring Amref and Philips to the table. So this is the perfect time to bring those folks into the conversation. Catherine, maybe I can turn the mic to you. Can you describe from Amref's perspective the vision around the Partnership for Primary Care and elaborate on the role of Amref?
Thanks, Natasha. I almost feel like Daktari has even spoken on my behalf. So basically, Amref has a vision and a mission. And I think our mission and vision really illustrates what it is we want to do in the health space, which is lasting health change. And we want this change to then be seen at the community level and be seen to especially benefit the underserved communities. And so we are very clear that one of our agendas as Amref is the universal health coverage. And we know that for this, we're looking at access and affordability for the services. And the services then need to be of good quality so that these citizens can then be able to get the care they need at these facilities. And so trying to reach the really underserved and underreached. And we look at it and thinking of how then we can improve this and improve the health outcomes across all disease areas. So when we joined this partnership, that was our vision and still continues to be, to demonstrate that it is possible to then have quality, affordable healthcare, even to the underserved rural population. And we are happy that as our CEO really is the co-chair for UHC, it's one of the key agendas. And as you mentioned earlier, the president has also backed us and said that this is one of the key agendas for Kenya. And we are happy to be in this partnership with our strengths within community health services, as well as managing facilities and generally just bringing our expertise from the years that we've implemented, looking at a sustainable, a bankable and sustainable solution, such that we don't have to have out-of-pocket expenditure to get good health, and such that the facilities that when you go seek care for whatever the condition you have or you're seeking care for, the facility is then able to treat you and to give you the quality care that you deserve. So this was our vision and this is what we've stuck to. And this is why we identified partnerships within Philips just to see how then we tackle the supply side of things and the demand side of things. So also embarking on ensuring that the citizenry then has insurance so that they don't have to have out-of-pocket expenditure. So Amref brings a capacity building role as well to the community health volunteers to increase demand for services, as well as register households for MHIF, and in essence also see how we can again coordinate facilities so that they're able to get back some funding that they can then inject back into these facilities and be used for what they need through that NHIF reimbursement. So this in short is what we are here.
Thank you so much, Catherine. We will definitely come back to this point you mentioned around NHIF enrollment, because I think that was a critical component to the financial sustainability of this model and critical to the model as we seek to scale. June, perhaps I can turn the mic over to you. Philips played a critical role in this partnership from conception to scale. Can you describe from your point of view, really what was the role of Philips and what encouraged you and Philips to join this partnership? Oh, June, you're currently on mute.
Thank you very much. Sorry about that, Natasha and team. And I want to acknowledge that one of the things that is very impressive about this partnership is a commitment and the passion really to improve people's health and their lives. And as Philips, we are committed to ensuring that we're able to reach 2.5 billion people in marginalized communities through health technology and innovation. So this particular approach for us is a very innovative approach. And so when we got on board, when we were invited on board, it was very exciting because we met a team in Makueni, because at Makueni, we have this very young head of departments and also very committed, responsible staff. And so what we did is that we're able to work together and agree on the 24 health facilities that we had to assess. And after assessing these health facilities, we came back to the table and were able to identify which facilities that we need to start implementation at. The different parameters of assessment were around the infrastructure. We're also looking at staffing, pharmaceutical, laboratory, as well as economic activities around the health facilities. And based on that, we did a report, and after analyzing the report, we went back for a second meeting. I think this is important because one of the things that it shows us that health is not just a concern of the Ministry of Health only, but several players. So when we came back with the final report, we were able to bring in other players, including the Department of Health, HR, pharmaceuticals. We even had to bring in civil works on the table so that we can discuss who will be responsible for what kind of piece. Yeah, so eventually we agreed that the Makueni team were going to mobilize necessary resources that were required. And these resources, like I mentioned, were around HR. Mcqueen was going to take care of supply chain and pharmaceutical work and also the civil work. And also Amref was going to look at capacity building, while Philips was going to look at the code creation, the solution design, and the workflow design. So after our meeting, we embarked to a co-creation exercise. And the beauty is that we're able to involve the customer first. Now, the customer to us are basically the community. We look at them as the customer, the county, the service providers at the health centers. And we sat with them together and were able to do a co-creation exercise whereby we were able to also tap on the issues that are affecting them and what they envisage as the services that should be provided at the facility, at what amount. And one of the things that we heard from the community is that they've been receiving certain services out outside Makueni, especially the specialized services outside the area where they were staying. And for example, people who are staying in Mali had to go far away to seek for ultrasound services, which we thought was not really necessary. So afterwards, we then got into a solution design from the co-creation, and we came up with the diagrams, what we see these facilities to look at. And this solution design was tabled before different stakeholders, and that includes the county as well as the health coordinating committees, because they're very important for political goodwill, and they're also managing the health centers. We're also able to share the same with the communities and looking at what workflows would be appropriate. At the execution points, I know that we got to a situation where we had to see that some of those walls were broken. Like in Mali, we had to create space for laboratory. When we get to Tini was completely dilapidated health center, whereby even triage and consultation was being done in one room. And we had to redesign it in such a way that we created space and also had to ensure that there was a maternity section that would actually provide a space for delivery by mothers. We also had to ensure that there was a separation between the pharmacy and the store because they were all mixed up. So we went to a place like Matiku, one of the health centers. And in this health center, there was no power. It was a very beautiful health center. So the first thing was to ensure that there can be installation of a solar system that can empower the health center. Because if you looked at it, there was space, there was maternity, which was not functioning. There were beds which did not have mattresses. And then there was a delivery room that was not done according to the required standards. So after doing this, then we got into the execution. All the stakeholders were excited. The stakeholders were all committed. I know that even for the county, when there was a need for civil works, we got into the big queues and they were able to deliver on time. Amref was very strong in coming up with the capacity building aspect of the health workers and to ensure that there's quality work that is going on using the quality parameters. I want to say that the most exciting things about these health centers, that efficiency has been experienced because some of the equipment that were installed, like the patient monitors, they're very important in taking vital signs. So they reduce the amount of time that the staff will take in terms of taking like measurements manually. We also had other services that were now included, like the ultrasound, that attracted additional funds to the health centers. But what was also exciting apart from those funds is that NHIF was able to accredit these facilities because initially they didn't qualify for accreditation. But now, because they were performing well, because they had the necessary equipment and necessary staffing that the county had allocated, NHIF had to accredit them. I think for now, I would want to say confidently that even with the current pandemic, there's a promise that the 3 facility is able to help in addressing those pandemic because some of the requirements for even COVID is space, yeah? And also trying to manage the volumes that comes to the facility. So with the clear workflows that we develop, I feel that, and I'm very confident that this is going to lead to sustainability and with the current NHIF engagement. Yeah.
That's fantastic, June. There were a couple of things there that really resonated with me, and I'm glad you brought them up. One was this idea of assessing the health facilities upfront, not only to understand the kind of infrastructure and investments that would be needed, but also to figure out where to start when it came to the feasibility study, how to find the right mix of facilities to focus in on to really test this model. The other thing that really resonated was this idea of multiple co-creation sessions and having the right stakeholders at the table to get alignment, 1, and 2, to really define the roles and responsibilities of the different parties. And the last thing that I'm really glad you brought up, bringing it back to the point that Catherine brought up, was this idea of NHIF and the fact that through this fantastic work, we were able to get these facilities accredited, which allowed us to then bring the additional financials into the model to allow us to achieve financial sustainability. The maybe one other thing that I'm remembering from your brilliant overview is the fact that you engaged communities and really sought to understand their needs and looked even at the additional services you could provide within these facilities in order to ensure that services were sought in level 2 and level 3, to Dr. Muwa's brilliant point that he mentioned earlier. How do you really incentivize people to seek out care in these lower level facilities in order to find cost efficiencies? Karnik, I would love to bring you into the conversation at this point. IntelliCap played such a critical role in evaluating the feasibility study across the 3 facilities, not just the baseline, but the end line. Can you talk to us a bit about some of the metrics we use to assess our effectiveness across cost efficiency and improving health outcomes, and what was it that we were able to achieve?
Thanks a lot, Natasha, and thanks a lot everyone who is present in this particular session. And definitely, as you said, that we were very, we were very glad to participate in this particular study, the feasibility study, and we participated both at the baseline level as well as the end line level of the feasibility study. And in the feasibility study, evaluation of this basically try to cover the entire continuum of the services provided across the facilities. And there were 5 critical impact pathways that we evaluated both at the baseline level and the end level. And these pathways included the quality of care. Was there any enhancement in the quality of care that was provided at the facility baseline? The one and the most that we also evaluated as part of this.
Sorry, Karnika, to interrupt you, but I don't think that we can hear you properly. Maybe you can move a bit more into the direction of the microphone, or maybe switch off your camera, because it would be such a pity if we miss your story.
No worries. Is it better now?
Perfect.
Okay, so sorry for that. Let me try switching off my video and then continue. So I don't know where was I when you guys stopped listening to me or couldn't hear me, but let me just quickly recap on the 5 key impact pathways that we covered as a part of the baseline and the end line study. The first pathway that we covered was the quality of the care. So we evaluated what was the improvement in the quality of the care at the beginning of the feasibility study versus at the end of the feasibility study. The second and very, very critical pathway that we covered was the financial sustainability of the entire P4PC model. And that's very critical because that enabled the team to understand whether this model can be scaled, and if can be scaled, what are the financial constraints or what are the financial revenue streams that they can use to scale this model from 3 facilities to 223 facilities across the county, and then even moving beyond the Makueni County to the other parts of the country and the other parts of the region. So the financial sustainability was the second critical impact pathway that we evaluated. The third pathway that we evaluated was the human resources for health, the improvement in the healthcare resources at these facilities, both in terms of the quality as well as the quantity of the healthcare providers. The fourth pathway that we evaluated was the reduction in the out-of-pocket expenditure for the patients in the catchment area of these facilities. And just to give you an idea, the catchment area of these facilities, it includes about 20,000 people. That's a good enough number to understand whether this feasibility study and at these 3 pilot facilities actually created an impact, not just at the facility level, but also at actual reduction in out-of-pocket expenditure for the patients or the beneficiaries that the targeting. And lastly, we also evaluated on the health systems governance. So what is the improvement in terms of the governance structures at all these facilities? And very, very from the baseline to the end line, the results were actually very stark and surprising in a positive way. June, Catherine, everybody has talked about that NHIF enrollment is a very critical component of this entire P4P model. At the baseline status, the enrollment in the NHIF was just 0.2%. And then at the end line level, the P4PC project has been able to increase enrollment into the NHIF and bring it to 15%. So that's a very significant change that the entire project was able to bring, and that shows that the models can be financially sustainable, because again, NHIF is a critical component of the financial sustainability of the entire project. The other critical component or the impact metrics that we observed was in terms of the skill deliveries. Again, there was a 48% increase in the number of skilled births from the baseline to the end line. That means 48% more pregnant mothers actually went to these 3 facilities to give birth rather than just giving birth at home or through the other traditional methods. So the 48% had the confidence, had the access to these services and believe in the quality of these services, and that's why there was an increase in the 48% in the skilled births between the baseline and the end line. The service utilization increased tremendously, and when I say tremendously, it actually is tremendous. The numbers are tremendous. There was a 92% increase in the service utilization across the average service utilization across these facilities, which again reflects back on the same factor that there was the improvement in the quality of the services, improvement in the number of the healthcare providers that are providing the service, the improvement in the availability of the various additional services that can be provided at these facilities. So the additional services range from ultrasound facilities, diagnostic services, laboratory services, which were earlier not available at these facilities. So that resulted in increase in confidence and ultimately resulted in 92% increase in utilization of the service. And lastly, overall, there was a 400% increase in healthcare revenues across these healthcare facilities, which definitely shows that the model like P4PC is sustainable, financially sustainable. Partners like public-private partners are able to develop a project and deliver and implement it. It can be very, very instrumental in improving the healthcare services.
Karnika, I think you've highlighted such great impact metrics that we've been able to achieve over the feasibility study. Given some of the audio issues, I'm just going to recap it for the audience members to ensure that they were able to hear. What Karnika was sharing is over the course of the feasibility study, we were able to see a 15% increase in NHIF enrollment within that catchment area from a 0.2% baseline. We were able to see a 48% increase in the number of skilled births. From a service utilization perspective, a 92% increase in service utilization. We were able to see a 400% increase in revenue from the healthcare services that we were able to deliver through these facilities. using some of the interventions that June mentioned earlier. So really tackling the healthcare system from multiple fronts, not just from a utilization perspective, but in terms of the quality of healthcare services delivered, as well as from the revenue we were able to generate and input back into the system in order to improve this and create that virtuous cycle. John, I'd love to bring you into the conversation. You bring such a wealth of knowledge and experience in setting up PPPs. The PPP model that we created here was really critical as the team aimed to transition from the feasibility study that really focused on 3 facilities to the 200 plus facilities that we were aiming to focus on for scale to get across the entire country. Can you describe how this PPP model was designed and what were the key steps that we needed to think about as we tried to create that PIIP submission?
Thanks, Natasha. Yes, and as you say, the feasibility study had shown the stark improvement that could be achieved through the health model under P4PC. So the next task was trying to take what was a feasibility study on three facilities, as you said, and largely funded by Amref and Philips, and together with their co-developer of FMO, taking that into a commercial and contractually binding model of a PPP, which could apply to the whole 225 primary care facilities that there are in Makueni County. So maybe before I jump into that, the process, given that it's a health conference and not a lot of people would necessarily know what public-private partnerships are, maybe I ought to just stop and say that the sort of key features of a public-private partnership are where a private party undertakes what is a public function, in this case, the provision of public health services, where that private party receives remuneration, which is very much linked to the performance of its services. So it's taking risk on the quality of performance of the services. And generally, it's through a long-term contract. In Kenya, there is a specific act, which Danny mentioned, of the Public-Private Partnerships Act of 2013, which sets out what is a public-private partnership in Kenya, and also has the dual function of actually setting out the procurement methods which must be used when there is a public-private partnership. And so there is a different procurement method for PPPs than there is for other procurements, which are governed by what's known as the Public Procurement and Asset Disposal Act. And the PPP Act generally assumes that projects will go down a conventional competitive procurement route, but it also wants to encourage innovation. And because of that, it allows for what's known as privately initiated proposals, because it's looking for the private sector to come up with ideas in the way that Amref and Philips have here, to actually look at different ways of delivering services that might be of great value to the government and the people of Kenya. And so that's what was followed here. So the PPP is largely following the model which was established in the feasibility study. So it's still Makueni County government who is delivering the clinical services and who are responsible for the staff. But Amref bringing its expertise to bear in relation to the establishment and development of community health units, and Philips with its particular expertise and equipment. So it's using that and combining that with help in private sector management rigor on some of the facilities to actually see how to deliver greatly improved clinical outcomes throughout the county. And the way that the PPP was developed was for the whole consortium to actually come up with a model which allows for a fixed price charge towards the county in respect of each type of facility. So actually taking a risk on performance at that level, subject to indexation, but also taking an element relating to income which will be gained from national health insurance from NHIF, which speaks to financial sustainability. And finally, also taking an element which is directly related to the clinical outcomes. So the model is designed to achieve the goals of all of the parties, that that all of them can benefit, and that it will work for the people of Makueni. It's a fairly traditional structure in some ways, in terms of having a project company with Amref and Philips as the traditional subcontractors, and also taking the other role of being some of the shareholders. They will probably be joined by impact investors. Funding is a blended finance model. So part through grants and looking at and potential grant providers in mind, but also with a limited amount of commercial debt there. So there is a way to actually make this financially sustainable. It's got to develop over the period of the contract, which will probably be about 12 years. And so that gradually the Makueni County government is able to absorb the full cost without actually, by the end of it, having any grant impact from other third parties. The consortium has trialed this and has shared draft proposals with the county throughout the process. And the final PIIP proposal, once that's approved by the county, will then go through to what is known as the Public-Private Partnerships Unit, and their supervisor body, the Public-Private Partnerships Committee, to approve two things. One is the fact that it can be done as a PIIP, so a privately initiated proposal. And then secondly, approval to the county to go ahead and negotiate the final contract. And all being well, that final contract will then be approved by the committee again. So that's the process that we've been through and are going through. And it's wonderful to be part of this, because I think it can make a massive difference.
Absolutely, and really appreciate the clarity that you provided there around the steps to submit that PIIP submission and why we went down the PIIP route. We're quickly running low on time, and I do want to bring in the audience, as we've received a number of really fantastic questions and comments, including how do we clone Dr. Mulwa? But perhaps I'll start with this question, and I'm going to direct it to you, Catherine. Are there plans to create a blueprint or a toolkit of the Makueni PPP model for scale up countrywide? And could this model with the partners be leveraged as a franchise model?
Thanks, Natasha. Yes, that is the plan. Based on what we learned from our feasibility, we find it a bankable and scalable solution, especially surrounding NHIF, which is now again in the middle of UHC. And therefore, we find it as a scalable solution that we can then pitch in similar underserved populations with the backing of the counties. I think we need to emphasize that this needs county backing and buy-in, and Makueni County has done it so well, providing the health, human resources for health, and chipping in where they could, especially for the infrastructure. So this sort of, if we were to scale it, and we are planning to scale it, you're looking at the same partners, and you're looking at, again, franchising it and seeing how we can make primary healthcare better for all in Kenya and in other countries that have similar challenges. And so it's a process, and we have learned a lot, and we know now what can work, and we are almost at the end of this process, and we have seen the great things that we've been able to achieve as illustrated. So yes.
Fantastic, Catherine. Dr. Mulwa, there's a question for you as well. over the course of the conversation, we focused a lot on affordability and accessibility. Are you able to elaborate more on the quality improvements and what has really excited you there?
Thank you. I think I did not deliberately talk about quality because I believe because there is the national standards, the global standards, and quality. And I am an expert in quality management in this country, and therefore to me is something that is very, very, very close to me. That beyond the services that the citizens are getting, what is the quality of the service that they are getting, which is very important. And quality is from the patient's perspective, is from the clinical perspective, and it is from the perception of the society of the quality of health. So it's something that we have what we call the Kenya quality model for health, which we are implementing. We actually have a program in the county to ensure that we continuously monitor, we continuously evaluate, we continuously improve the quality of services that are delivered to the citizens. And part of the partnership that we have with Amref and Philips is actually more of guaranteeing quality with all the inputs that everyone is coming up with. The major outcome that we look forward to is to ensure that the quality of services meet the expectations of the citizens and the clinical expectations, so to speak. And therefore, we are very, very, very concerned about quality. It is why we exist. It's why we do all these things. Thank you.
Fantastic. We're going to take one more question from the audience before we turn to the final question that I have for you all. John, this question is coming to you. Do you mind elaborating on the shared risks and responsibilities, this pay for performance model?
Yes, maybe if I take on the different elements. So maybe probably the easiest first starter point is if I look at the equipment element and equipping the facilities. The consortium will be paid only when the equipment is there and it's working throughout the life of the contract. So if there are bits of equipment which are not working, then the consortium's income will be reduced as a result. So there's a direct correlation between the level of service. It's not a pure, we'll sell the equipment and goodbye. This is a different model. That equipment has to be there, it has to be working. In relation to the community health units and in terms of the management of overall supervisory management of facilities, there will be different metrics. So once they are up and running, there will be metrics which will show whether or not they're meeting their expectations and the services are being delivered to the standard in the way that Dr. Moore was just describing there. And that will help also having a relationship to the income of the consortium. So what we're trying to achieve through this is incentivization of the consortium financially so that they deliver what is planned and how it will work. I think I'll stop there.
Fantastic. Well, in the last 5 minutes of today's call, I have one question to pose to each and every one of you. There are fantastic learnings that we have from being part of this journey over the past 4 years. And as we look to we look ahead and think about the role that PPPs could play in driving health outcomes, what would be the one lesson that you would want the audience members to take away from this journey? Dr. Mula, I'd love to start with you. What is the one thing you want to emphasize as audience members think about creating similar models or trying to extrapolate the learnings from our experience?
I would like to say that one, and this is really the most critical part, is to have a shared vision in the partnership, because Amref, Phillips, and Makueni County clearly have a shared vision of what we want to do, what we want to achieve together, and our working is on the collective of that shared vision and not the interests of individual organizations. And I think that is what I would say, because I would not want to paint a picture that it has been smooth sailing. It's an easy straight line. It has been bumpy, but because we already know where we want to go, what we want to achieve, we've always been able to address the challenges that we face on the way. And that is exactly what I would say. What am I saying? It's about the commitment levels of the organizations to a common cause. Thank you.
Fantastic point. A shared vision and that commitment to that vision. Catherine, what might you add?
It's like I was on the same wavelength with Dr. Mulwa, but what I will say is, for me, one of the key learnings from this is start from somewhere and co-create, because we have this idea that it will be perfect, but as he said, it has many hitches, but if you have a direction, then it works. Again, bringing in key experiences and learnings as partners and sharing them and being able to then implement through them, because Philips has their expertise, Amref has its expertise. That has really helped us in working out a model that is working. And so those are my key learnings, but also what to take home is, once the community is satisfied, we are all satisfied.
I love that you brought in the community element. June, from the Philips side, what might you share with the audience as that one key takeaway? June, do we still have you on the line?
Yeah. So one of the key takeaways is that is one of those people who have implemented community strategy in the public sector and was responsible for even helping in developing community health manuals. And in most of the times we've talked about mainstreaming the PPP in the programs that we have. So this PPP model provides an opportunity, but not just a say that we are mainstreaming PPP. And one thing I realized and I learned is that when we bring in the private sector, then we're bringing in other aspects of accountability and also efficiency with any projects that you're implementing. So I would encourage the counties, I would encourage the government to think about PPP when it comes to health, because I know it's a new domain, but it's something that can be explored further.
I like this idea of being innovative, trying this out, and ensuring accountability against what we're trying to achieve. Karnika, what might you add? Oh, Karnika, we can't hear you.
Am I clearer now? Is it better? Okay. Sorry for that. So one key takeaway that I will like to add is that thinking about the scalability. So not just launching the project for a pilot or doing a testing, but from the very beginning, think about how this initiative can be scaled, how it can be taken from 3 to 300 to 3,000. And I think the way this entire P4PC or PPP project has been designed, the scalability has been there in mind from the very beginning itself. All the learnings, all the activities while they were tested, but at the same time, scalability was considered. So scalability, think about how to scale.
I love this idea of scalability early. And John, final words. What's the learning you'd like to share with the audience? John, you might be frozen. Can you still hear us? John, if you do end up hearing us, please feel free to share your thoughts in the chat window. But we've quickly come up on our time. Dr. Mulwa, Catherine, June, Karnika, and John, just want to thank you so much for your fantastic insights today on the power of partnerships and the PPP models that can help us to strengthen primary care. To the audience, as we look into the next decade and the obstacles ahead of us from achieving health and well-being for all, or SDG 3, I want to inspire you to think differently. We will really need to break down the silos in which we've normally operated and bring together the kind of capabilities that you've seen across the partners at the table today to achieve our success. PPPs can play a critical role in helping us to achieve that, but they need to be designed with purpose and have the right partners at the table. So please consider this as you are embarking on your health efforts. Thank you so much for joining us today.